This is Dr. Susan Hudson from Texas Fertility Center with another episode of Fertility Docs Uncensored. And I am joined by my amazing, entertaining, and delightful co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas.
Hello.
And Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody.
How are y'all doing today?
Doing great.
Good.
It's good. It's spring. It's almost summer.
No, it's summer.
It's summer. It's summer in Vegas.
It is summer here.
But it's beautiful. We had beautiful weather today. It's gorgeous.
It's been raining and raining and raining, which we're very excited in Texas because, like, in our part of Texas, we've been in a drought for like 3 years or something.
Yeah.
So I'm hoping this is the year that my grass like reemerges to the beauty it was when I moved into my house.
Hopefully you won't get flooding. It seems like droughts and then floods and droughts and then floods.
It
And
does.
there's nothing in
But
between.
it's been kind of spread out, and so we're enjoying it while it's happening. So Abby, I understand you have had some visitors recently.
Yeah, we've had some springtime visitors, and they're kind of unwanted visitors. So we have a pool and we have a bird feeder out by our pool, and so it's been kind of fun because we've attracted creatures great and small. We've attracted all kinds of cardinals and birds and like squirrels. And so our latest furry friends we came home one day and just happened to notice that this mallard duck, who was very pretty, and his wife were just swimming, her partner were swimming around in our little pool, and they were so cute. We could see their little feet fluttering, and we thought, oh, that's so cute. And then we talked to one of our friends, and they're like, oh my gosh, you don't want them in your pool. They'll keep coming back. Once they find a spot they like, they'll never go away, and they poop everywhere. And so we left for the day. We thought, well, we'll just leave them alone. So we come back. Poop is everywhere in our pool, all around our pool, everywhere, so I'm like, okay, this is not a good relationship here. So finally we, with much, we hated to, but we shooed them away, and they flew, and they looked like they were gone, looked like we'd never see them again, so we're like, okay, maybe they'll find some other place. Well, that was 3 weeks ago, and every day we're on the duck watch. Are they going to be back today? Or are they not? We even bought these owls off Amazon, and they don't actually hoot, but their heads like turn. And so for 3 or 4 days, we didn't see the ducks, and we're like, oh, great. We're done with the ducks.
You have to move the owls though.
Well, we did move them a little bit. We didn't move them enough, I think, because the next day I come back and the mallard duck is like sleeping right next to the owl. So clearly they're not worried about the owls anymore. So we're kind of at the point where we're either going to have to buy something that actually makes owl noises, maybe, or we might even call. I almost think we need to box them up.
Duck is yummy.
I know. My brother-in-law, who's a hunter, was like, "Boy, let me have at him." I'm like, no, they're so cute,
I have to say, duck is my favorite meat in the whole wide world, which I didn't realize until a few years ago. But oh my goodness,
they're so cute though when they swim. Like he swims one way and she swims right next to him,
but
and
they're floating in your pool, Abby.
Yeah, I know.
What if you get like a water gun, like something that's innocuous but annoying? Although they're ducks, so maybe they don't care.
I don't think water will bother ducks too badly.
Well, no, but if you like
the pressure of the water,
the irregularity of the water, like it's not like rain, it's not like a lake where it just sits there or is steady.
Yeah, but we'd have to physically be there to do it. The problem is they leave, they come and eat breakfast, and then we shoo them away, and then they're gone for several hours. I don't know what they do. And then 3 hours later, they're back swimming in the pool again. So when we get home from work, there they are in our pool. So I don't know what we're going to do, but we'll figure something out. But I don't want to kill them, though. That's the only thing I don't want to do.
I don't know. We could
maybe by the end of the summer, I may change my tune.
I was going to say, should we start putting bets on how long the mallards are going to last at Abby's house before she A, finds a way to truly get rid of them, or B, turns them into Sunday dinner?
I know. Yeah.
Sunday dinner sounds good to me.
So cute, though.
All right, let's go ahead and do a question of the day. Hello, I love your podcast and have listened to over 100 episodes since I found it last week.
What?
Wow. Oh,
you're amazing. That's awesome. Thank you. Thank you for what you do. I was hoping for your thoughts on my timeline for getting pregnant and whether I should bring it forward. I'm currently 26 and would like to start trying at 30. I have PCOS diagnosed at 16 after 3 years of extremely irregular periods. I have 25 to 35 follicles per ovary with a recent ultrasound. I had laparoscopy in 2017 and was diagnosed with stage 2 endometriosis, endosalpingiosis, and suspected adenomyosis. I am heterozygous for factor V Leiden. I have a strong family history of autoimmune disease, AMH 12.3, BMI 24, TSH, LH, FSH, prolactin all normal. I'm about to get married and will be unable to afford IUI and IVF. Oh, sorry, I will be able to afford IUI and IVF. So
But she doesn't say how many kids she wants.
she does not,
And she's never tried to get pregnant thus far, right?
as far as I'm aware.
And she
Okay.
doesn't say anything about her cycles, although with the diagnosis
ir-
of PCOS, we can assume some
Long
irregular-
history. She had irregular periods for 3 years, like when she was a teenager. So irregular periods.
I mean, I always default if you are smart enough to be actively doing this research ahead of time and you know all these things about yourself. I mean, the combination, like the PCOS, fine, whatever. That bothers
We can
me.
treat that. We can treat
Yeah.
that.
We can treat
It's more
that,
the
but
endo and the
the endo
adeno.
and the
all
adeno
that
and the
stuff.
autoimmune disease, like I would, if you're good and you're healthy now, take it and run with it and have a baby and like build your family before you run into problems.
But it sounds like she wants to start in about 4 years. So I would almost say you might be a great candidate for freezing eggs.
Egg freezing. Yep.
Freezing
Embryos.
eggs. But I would start, you're 26. I would say freezing a round of eggs and maybe a subset for embryos. And then when you're ready to start trying. And I mean, she's going to have, I mean, she has 25 to 35 follicles.
She's
on
going to
each
have a lot of
ovary.
eggs.
She's going to have a lot of eggs. So, you know, if you want to take 10 of those eggs and create embryos and then freeze the rest of the eggs. And then when you're ready to start trying, just start trying on your own and then hold these for potential later pregnancies. I mean, you are obviously a planner. Otherwise you wouldn't be listening to us right now, which is amazing. That's kind of my level of planning.
True story.
And so, you know, that's kind of what I would think. I would say do an egg retrieval, take a segment, maybe 10 or 12 eggs, create embryos from those, freeze the rest of your eggs. And then when you're ready to start trying on your own and hold these for the future as your insurance policy.
So I would say similar thing, but I would say, you know, how many 26-year-olds do you get them on Clomid? They ovulate and they're pregnant the first cycle. So you know, there's nothing wrong with freezing eggs. I think, and I don't normally say this because you have a partner, but I think it might not be a bad idea because it's cheaper and you're young. And you said cost wasn't an issue, but it'll be half the cost or less if you just freeze eggs and don't create embryos. I think either one's fine, but I think there's a reasonable chance if you get on Clomid, you know, provided your endometriosis is not a big issue, you may get pregnant really, really fast. And then you'd have frozen eggs and frozen embryos that maybe you would or would not use at some point in the future. So I think in this situation, you could consider just freezing eggs for right now because you're young and they'll probably freeze and thaw pretty well, and then create embryos down the road if it turns out that trying on your own doesn't work.
I tend to default to freezing embryos whenever it is the reasonable option to do. This is one of the few cases where I would say splitting and doing some eggs, some embryos actually makes sense because of your age and because of your egg count. Most of the rest of my patients will know that I'm not otherwise a real big fan of that, but mostly because it's people who have like 5 eggs and they're wanting, hey, can I split them? No, the answer is no. This will not work to your advantage. You know, I think a lot of it will depend on what size family you want. You know, if you want 1 kid, you got a lot more leeway than if you want 3, 4, 5, where if you want multiple, I would absolutely say put some eggs on ice, embryos on ice, whatever floats your fancy, and get that started. But if you just want 1, then you do have a little bit more wiggle room. I think it really is the endo and the adeno that make all of us a little bit uneasy. The
Yes, that's a little bit of a question mark.
Yeah, the PCOS by itself, we can live with that, but endo and adeno are problem children. Like they come back and they cause all kinds of drama. And if your periods aren't particularly painful or heinous now, that's great, but that can change over time. And so, you know, for something that's as important as this, I would tend to go more for the aggressive planning ahead, but that is also my MO as well. So it depends on your style.
Agreed. All right. Great question. Well, let's go on to our episode for today. So, probably a few episodes back, we recorded about the medicines for IVF stimulation. So this is kind of part 2 of that, where we're looking at what medications are involved in a embryo transfer, usually a frozen embryo transfer. Some of the medicines are going to have some overlap. We mainly do frozen embryo transfers within our practices. So I think that'll probably be the focus of what we're looking at today. So let's start at the beginning. So if somebody's getting ready for an embryo transfer and they're getting their body ready to do those things, Carrie, what are some of the things that you might start somebody out on in preparation?
So a lot of times birth control pills are a good start for this process. And even though pretty much every fertility patient gives you the stink eye when you say, all right, well, let's put you on some birth control pills, because they're like, woman, do you have no idea why I'm here to see you? Like, are you sure you're the professional? Are you sure you know what you're doing? Yes, absolutely. Oftentimes we will use birth control pills in order to help us with timing. So for example, a lot of patients travel for work, or they have work
Regular
obligations, home
periods.
obligations, family obligations, irregular periods, you name it. And controlling their cycle is a really helpful thing to do. Birth control pills allow us to do that because we'll put you on a pill, and oftentimes we'll just do the active pills up until we're ready to start, at which point you'll stop the birth control pills, get a period, and we will rock and roll. So I think that that's probably the one of the default meds. You don't have to use them, but there are many cases where it's a really helpful technique to have.
Mm-hmm. Abby, what are some other prep medicines that you've used in the past?
So actual medicines to thicken lining would be things like some sort of estrogen. So there's
Well,
different
like
ways
in
that
preparation, like
preparation.
before we're even
Before you're
getting
ready to
started,
start
before
estrogen.
we're ready to start.
Sometimes we'll put patients on doxycycline or some sort of antibiotic to make sure that there's not kind of a low-grade infection in the uterine cavity. I don't do this routinely, but sometimes people will use like Medrol or some sort of anti-inflammatory agent in the endometrium as well. But probably doxycycline, some sort of antibiotic, is sort of the only other thing I typically use in cycles.
So sometimes when I have people who are getting ready for cycles, and I don't usually use this as a first line, this is for when people have tried to prepare their lining and something hasn't gone right. I use the combination of the birth control pills with some injectable Lupron
Yep.
to help suppress the ovaries to keep them nice and quiet as long as we need to. So the key to success with frozen embryo transfers is control, control, control. And once in a while, when we're preparing the lining, things don't go the way we expect. And so we have to add in that Lupron. And I would say less than 10% of my patients have to use that anymore. But that is something. And not really a medication, but a supplement. This is the time you need to be on your prenatal vitamins. I can't tell you how many times we tell you be on prenatals, and then I come to the day of embryo transfer and reviewing their meds all over again, and somebody's not taking prenatal vitamins. Oh my goodness, take your prenatal
That's
vitamins.
when you really need to take them.
Yep.
I know you're tired of them, but like this is when it's really important. So get on your prenatals. Ideally, we're going to either need birth control pills or not use anything going into kind of the prep time. But occasionally, like I said, we have to add that Lupron, and we'll continue it on until you start your progesterone.
So, Susan, when would you do Lupron versus not doing Lupron, for example?
So I don't generally start Lupron on anyone if it's their first cycle. Okay. So if somebody has gone through an FET cycle and they have ovulated through and had a high progesterone level before I was starting their progesterone, those are the people that I'm going to start. Now, the people who are most likely to need this are ladies who are older, so in their upper 30s or in their 40s, or if they have significant diminished ovarian reserve. Those are the ones who are most likely to end up ovulating through. Carrie.
I also use Lupron in this way when I have patients who are traveling, because it gives us an extra layer of control, particularly when you've got a long distance and you have a set of dates that you really need to make because of all the travel and the hoopla involved. I will use it a lot in those cases. There are some patients, and it's not my default. We have used it often enough that I have no problems using it as a default. I usually don't because of the expense of the medication. But
And
it
who wants to
doesn't
be doing more injections than you have to?
exactly, like it's kind of annoying, but I think effectiveness wise, it's equivalent to all the rest of what
Mhm.
we do. There
Yeah.
are times that I will extend the Lupron out to do like a 2-month prep, particularly in patients who have endo, occasionally adeno, when
Mhm.
if they've had a failed transfer, if they only have one embryo and we have to be uber cautious, that's when I will tend to do that a little bit more. That I get flack for that when I do that for my partners, but I think it helps in certain cases.
Well, I think it goes along with the people who, we had a episode recently about people who have positive tests on Receptiva or BCL6
Yeah.
testing. That Lupron is going to help suppress that. And along those lines, I'll often use a medicine called Orlissa if you're among those people that I'm trying to suppress. And sometimes I'll use like a month of Orlissa and then I'll go into Lupron for the actual embryo transfer. So there's lots of ways for us to play with this. So, so Abby, you were kind of getting into this. So now that we have everything ready to
The
start
prep medicine.
the prep medicine, what's your go-to?
So my go-to, really any form of estrogen, I think works pretty effectively. I tend to go more toward patches. I think that they give you more of a constant estrogen level, and there's not as, it's not like if you give a shot, you have a big surge of estrogen probably, and then it drops down a little bit over a few days. It gives you more of a constant level. I think it's tolerated better by patients. They prefer to do that a lot of times as opposed to give injections and things like that, or use vaginal medicine or something. So that's sort of my go-to. I think the downside to patches, though, is just that they're a lot more expensive or somewhat more expensive for patients. But generally, that's what most of our patients use to build their lining up.
So when you do patches, kind of what's your formula?
So we usually start with 2 patches for 1 week, and then 3 patches, and then 4 patches, and then they come in for their lining check at that point. And usually, if their lining looks good, then we just go with that. We figure out when we're going to do their transfer, and then start the other medicine that we're going to talk about in a minute. If not, sometimes we'll even add vaginal medicine, which really works pretty quickly to help build the lining up too, as sort of another bump to get their lining thicker.
So Carrie, how do you prep?
So my default tends to be, for my local patients, tends to be just pills. For my GCs, I tend to use pills and patches.
GCs?
Gestational carriers. So people typically who are traveling, coming from a distance where I need,
Distance. Yeah.
real even. I don't have the same kind of ultrasound control over them, things like that. That tends to be a little bit smoother, I think. But for my locals, I just use the pills. They're cheaper, they're easier, it works. We'll add in the vaginal. I very rarely use the injectable estrogen. It is not my favorite. And so
But we all have a handful of people that's the only thing that works
yeah.
too.
Yeah.
I mean,
Unfortunately.
the name of the game here is whatever it takes. And so
Yeah.
the majority of us will have our first, second, third line treatments, and then well, crap, fine, I gotta go with this the treatment as well. And so the injections are well, shit, all right, fine.
Well, and not only estradiol valerate injections twice a week, but sometimes, and I know you guys have done this too, if you have a patient you just cannot get their lining to respond, sometimes they respond a lot better to their own endogenous estrogen than they do the estrogen you give them exogenously. So a lot of times when people have really thin linings, sometimes if we start them on FSH injections, the same injections that patients take when they're trying to stimulate egg development for IVF, we start them just on a low dose. And really the end game is the lining thickness. It's not if you have a follicle, it's not necessarily trying to get you to ovulate. But sometimes patients, even after 4 or 5 days of that, even though they don't really have a follicle there, their own endogenous estrogen has built up their lining. And then at that point, we're good to go.
So do either of you ever use Femara or Letrozole to prep linings?
Yes.
In order to do that, somebody needs to have the ability to ovulate. They need the ability to kind of track their cycles a little bit more closely. It's not required, but it's certainly helpful. This does not work in menopausal patients
or long distance patients.
It does not work long distance. I mean, it can if you have extraordinarily easy access to travel arrangements, but but yeah, we'll do that occasionally. It was all the rage for a couple years there, and I think it's kind of simmered down just a little bit more recently, but it's a very effective technique when you need it.
A good point to add there is because I'll have a lot of patients will say, well, I'm, maybe back for their second baby. And they're like, I don't want to do all those medicines. What else can I do? And so we call it in our neck of the woods, we call it a natural cycle FET, although it's really not natural because you take Femara and we still give you progesterone. But it is a way to kind of avoid some of those medicines. And kind of get through a cycle, without having to give as many injections and things like that. In our practice, though, I do tell patients it's a little, because some people will say, well, is it more effective? And in our practice, it's a little less effective. So a lot of times when I tell patients that, they're kind of like, well, maybe I really don't want to do that. But certainly, if you're on baby number 2 or 3 or whatever, people are a little more open to doing things that are easier and don't require so many visits to our office.
Right, right. So those are all great things. And so when we're going through this FET cycle, so we've built up the lining, okay? We know the estrogen level is appropriate, and you've probably had a progesterone level, making sure it's nice and low. So why is that low progesterone level a big deal? Why do we care?
Oh, it's a big deal because progesterone is really the thing that gives us the window of implantation. So if you put an embryo in somebody and they haven't been primed with estrogen and haven't gotten the right exposure to progesterone, whatever the magic that happens in the endometrium, which we really don't know what that is, the magic doesn't happen if you don't have a certain number of hours of exposure. And 104 to 144 basically is that time of exposure that you need to have with progesterone. On the flip side, if for some reason you've ovulated or you produce your own progesterone and we don't know about it, that's bad because you're out of that window. Your embryo doesn't really match up with the way the endometrium is, and therefore your embryo just is not going to implant well. So progesterone is really important to be there at the right time, but not at any other time.
Absolutely, absolutely. And there's some different ways to do progesterone. So what are the most common ways we do progesterone?
So I would say that intramuscular injections are extraordinarily common, and vaginal progesterone.
And not very well liked, we should add.
And not well liked. Although I don't think the vaginal progesterone is terribly well liked either. Like I haven't seen anyone.
They all have their downsides. So let's break these up.
Agree. Yeah.
So progesterone and oil. So these are the injections that usually go in your booty. All right. We highly advise you not to
booby.
Right. Booty.
But
if you are having to do these injections yourselves, I highly recommend you not do them in your thigh or in your arm. Yes. And the reason is because you are not going to be able to walk or use your arm. I have seen this happen time and time again. So try not to do that. But progesterone and oil, what are some of the nuances about progesterone and oil?
So there's different types of oil that can be used. So I would say the most common at this stage is typically sesame oil.
And the cheapest.
And it's the cheapest, which is why it's the default. But if you have an allergy to sesame or you don't tolerate it, the compounding pharmacies can use other types of oil. So I think if I had the ability to
What's your favorite?
Ethyl oleate. It's everybody tolerates that so much better, but it's more expensive. So that is why it's not the default. But for people who don't tolerate sesame or have an allergy, that is my easy second choice. They can do it in olive oil. I think at one point in time they did peanut oil until everybody in the free world had
peanut allergies.
Like that would be just a stupid way to die. Have you guys ever heard the random song, Dumb Ways to Die? It was a PSA for the metro station for Australians. And so if you ever look for a random catchy tune, Dumb Ways to Die, it's funny. But
what's that got to do with peanut oil?
If someone has an anaphylactic reaction to peanut oil because they have an allergy that is more severe, then
it's a dumb way to die.
It's a dumb way to die, and it's avoidable. Okay. So let's not. So those are most of the oils. Do you guys have any other oils that you default to?
I know there's another one or two, but I can't come up with any at the moment.
Yeah, I think there's all kinds of varieties, especially when you go to the compounding pharmacies and stuff like that. But I'm a big fan of the ethyl oleate. And I mean, yes, it is more expensive, but in the big scheme of what you're paying for your IVF meds, it's the cheapest thing you're buying. So if you're not liking yours, you might look at just paying cash if you happen to have insurance coverage. So when we look at our vaginal preparations that are available in the US, one of them tends to have a gritty, what's a gritty
Consistency.
consistency after the medication has absorbed into your system, and the other one tends to have a watery discharge. So that's the reason why people are kind of, complain about no matter what they're getting. But, a combination, either straight PIO or a combination of PIO with the vaginal tend to have very good results.
So just to break it down, the vaginal is either Cronone 8%, and I don't know how you guys do it, but we usually do it twice a day if somebody wants to switch to that. So it's kind of like medicine that you would use if you had a vaginal or like a yeast infection, but you're doing it twice a day. So most of the progesterone component absorbs, but it's the carrier media that doesn't. So that comes out in your underwear. So if you, use yeast medicine twice a day for, like 8 weeks, you'd have a lot of discharge. And I'm like you, Carrie, most people really hate that almost as badly as they hate the IM shots. And I think Cronone right now, as of at least what I heard of as of 2 days ago, it's on back order and we can't even get it right now.
Again.
So, yeah, and who knows when this episode comes out, what the situation will be. But for the moment, we can't get it. The other medicine is endometrial, and it's described as like a little fizzy pill that you use 3 times a day. And discharge occurs with that as well. But
that one has
you
watery discharge. So
3 times a day. Yeah. So those are your options kind of.
So how do we not take progesterone?
Orally.
Why do we not take it orally?
Because it doesn't work.
Absorb well. Yes.
Okay. So the liver essentially deactivates it and it doesn't work. And so I had a patient recently who was like, I read that orally is the way to go. And I'm like, hard stop. Nope.
So this is an aside question. I've never done this, but I had a couple of patients who've come from an outside practice that's no longer in Nashville, and they did prometrium vaginally. Have you guys ever, done that for an IV? I've done that for other patients. Have you ever done that for like patients that are doing an FET and measured levels or know anything about that?
Never as a primary way. Like I've added it as supplementation for people where I absolutely had to, but our default is a high dose of IM progesterone.
Yeah.
And unless a patient just flat out doesn't tolerate it for other reasons, I never have to do the other stuff.
Yeah.
So I don't use it very often, thankfully.
Yeah. I've kind of ebbed and flowed through my career. Like I started out with PIO only, and then for a long time I did a combination of either endometrial or Cronone with PIO. I'm kind of going back to PIO only right now. But no, simpler. I haven't used I've used progesterone, like prometrium vaginally for IUI cycles, but I don't think I've ever done it for IVF cycles. Yeah. The big thing is the other stuff has been well tested. There are good studies to support non-inferiority, meaning they're not worse. We can't really prove that anything's better at this point, but we know they're not worse. And so that would make me a little bit more nervous about going off the reservation.
Yeah, and the one important thing we forgot to mention, which we all know, it's kind of the elephant in the room, but the reason we do IM progesterone, and I probably at least once a week I tell patients this, is because we can measure blood levels. So if we give you a bunch of progesterone, we do give you a bunch, we know that you're getting the right amount. We know we don't have to worry about it if you're getting intramuscular progesterone. We worry a little bit if you're getting the other forms, the vaginal forms of that, because we can't really measure. All we can measure in your blood is your level, which is going to be really low. We can't measure the effect or the impact it's having on your endometrium. And so therefore we get really nervous if we can't measure it. And so that's why we all default to that. It's been around forever. We used it for a long time. We know it works. It's a pain in the butt, literally and figuratively, but it works.
Good stuff. Good stuff. So, Abby, earlier you were talking a little bit about adjuncts. So things that, some of us have our steroid protocols or antibiotics, those types of things.
I call those the voodoo protocols.
Yeah. They are. But sometimes they work.
Yeah.
Sometimes they work and nothing else has worked. So what are some of y'all's things that you kind of add in to, contribute to your kitchen sink?
Well, I think antibiotics are useful just because, if you think about it, there's really not routine testing for endometritis. There's not an easy way to pick up inflammation in the endometrium. We talked to Bruce Leslie a couple of weeks ago, and he is with the Receptiva assay group. And one of the things he talked about was back in the day when we used to do laparoscopy routinely, we would pick up endometriosis, for example, which was one of the causes of inflammation. We don't really do endometriosis surgery anymore. And we really don't routinely give patients antibiotic courses for any other thing that we do. So if somebody did have a low grade infection, which I think those people are probably far and few between, but I think there probably are some, we would miss those patients, if we don't do some sort of antibiotic treatment. So it's one of those things, it's probably voodoo for most people, but I just sort of feel like that's an area that that base is not really covered if we don't do that.
Carrie, what else do you add?
Viagra and cabergoline are part of my voodoo methods, both to increase blood flow to that area.
Mhm.
I will pull those out when I'm looking at the kitchen sink if nothing else has worked. Using FSH and getting a follicle and giving someone a trigger shot to get their own endogenous or self-produced progesterone. I've definitely done that before.
Mhm.
Usually that's an after the fact thing, meaning I start progesterone, nail the timing, and then give the HCG so that they've got that little extra boost. I would say those are my default voodoo methods.
And how long do you continue the medications?
Like once they're pregnant.
So you've gotten your positive pregnancy test, and how long, and this is another one of those that there's a million answers
There's
to
no
this
right
question.
answer here.
There's no
So
right
don't-
answer.
so
So
don't-
I'm
don't
actually
fuss
really
at your
curious to
doctor.
what we all three do.
Yeah, don't fuss at your doctor if they don't do whatever we do, because
Yes.
we all probably do something different. We generally go to estrogen every other day at week 10, and at week 12, we discontinue both estrogen and progesterone.
What do
And
you do, Carrie?
we do levels, actually. We do check levels too before we stop everything.
We start the taper usually between 9 and 10 weeks. So what we'll do is we'll check the level, drop the dose, let it settle a couple days, check the level, drop the dose, let it settle a couple days. And usually by the time people hit 11 weeks, they're effectively off, but that taper starts, 9 to 10-ish. What do you do, Susan?
I'm more of a minimalist than you guys are. So I don't historically, unless somebody's having problems, I don't keep on checking levels. And at 10 weeks, I come off of the estrogen and progesterone. If they're anxious, we can wean off between week 10 and week 11.
Mhm.
But the placenta should have done all its stuff at week 9. So we've already
Yeah.
given it an extra week. And like we said, I mean, there are practices. I mean, obviously it's none of us because we just told you what we do, but there are some practices that stop the stuff like after positive pregnancy test.
Mhm.
And there's as I mentioned before, there's an art to art assisted reproductive technologies. And this is definitely one of those things that I don't think there's great data to support what we do. I mean, I think the three of us feel good about once we know the placenta should be doing what it should be doing, going from there. And that's kind of the big premise of where our decision making is.
Yeah.
So I have a question for you all, and there's not an answer. Whoever's listening, there's no right or wrong answer here either, because nobody knows. Just curious. 2 questions actually. What lining is considered as a good lining thickness for you? So right before we start the intramuscular progesterone, we check the lining thickness. The other question is, we also check estrogen on that day. Is there an estrogen level at which you would be worried that you would add in estrogen, or do you just go, if the lining looks good, you don't care what the estrogen level is?
If the lining looks good, I go forward.
If the lining looks good, I go for it. If the estrogen level is aberrant, meaning it was really high and then all of a sudden really dropped, I will keep a closer eye on it. And I'm a little more inclined to add a little extra, either that visit or more often the next one. Because sometimes it's just they took their dose at a slightly different time. And so
Right.
the level is dropped, even though just because they took it at noon instead of 8 p.m. And so they're a little bit further out from their dose when we check them. But for the most part, I don't worry too much about estrogen levels as long as everything else looks good. I will sometimes supplement, but I don't lose sleep over it.
The reason I ask that question is every now and then I'll have patients, particularly when we're at the post-IVF consult visit, if things didn't go well, they'll be like, well, the estrogen level was only da-da-da-da, and you guys never checked it again. Why didn't you check it again? Or why didn't you give me supplemental estrogen? And that's what I say, if your lining looks good, that's really the endpoint we care about. We don't really care what your estrogen level is. And so I just wondered what you guys thought. In the last question,
I think we use the estrogen in case your lining isn't good to know where we need to go from there. But if it's good, it's good.
Yeah. And what about lining thickness? What lining thickness would be a good one in your practice?
So I feel warm and fuzzy about over 8. I don't bat an eye over 7. But I'm also very cognizant that I have absolutely gotten people pregnant with a thinner lining. I think kind of your delta of where you start and where you go is probably more important. On those people, those are ones that I definitely like to definitely have something that's very perfectly pretty trilaminar. If it's thicker, I'm much more, judicious, and it's more the thickness that I'm worried about.
So I'm typically looking for about 8. On the flip side, when it gets to be like 15 or more, I start to get a little uneasy just because I feel like I don't see as good a results with those. I still see people get pregnant, but once you're much beyond 15, I kind of like, well, do we want to do this again? Do we want to stop and reset? I am similar to Susan, usually 8 is my warm fuzzy spot.
But you wouldn't cancel if it wasn't 8 though, right?
It depends on the circumstances and it depends on the patient. Like if I have a really anxious patient where this is the only embryo she has, then
maybe
maybe I'm a little bit more inclined to. But if we're on a second cycle and we hit the same thickness and it's gorgeous, we're just going to transfer. But a lot of the times it's actually because patients will ask up front, what are you looking for? And I'll say, ballpark around 8, but there's variation depending on what's going on. A lot of times patients will go, why did you go ahead with a transfer?
Right.
If they get pregnant, it's great. But even in the best case scenarios, there's 30% who aren't going to get pregnant despite a good embryo and everything else looking beautiful. And so oftentimes it's actually a more psychological decision than anything, because if something doesn't work, you need to know that you were comfortable with all the decisions you made leading up to it. And some patients are a little bit more flexible about, yep, let's give it a try. Others are like, nope, I want this to be textbook before we go forward, unless we have done so many things that is no longer an option.
Yeah. All right. Good stuff. Good stuff. Well, I think this has been a great episode. We've talked a lot about frozen embryo transfers and why we use the medicines we do and when we use them and options available, because there absolutely isn't
lots of different ways to do
a definite right or wrong option. So to our audience, thanks for listening, and be sure to tune in next week for more. Also be sure to subscribe and leave us a review in Apple Podcasts. Would love to hear from you. We are also on Instagram, Facebook, and YouTube, so make sure to follow and subscribe to stay updated on all things fertility.
You can also visit us on fertility.censor.com to submit specific questions. All questions will be answered on the podcast for our Ask the Doc segment. We love episode ideas and we love to hear from you. So let us know what you're thinking.
Start marking your calendars. October 28th in New Braunfels, Texas. So right between Austin and San Antonio, we are having our first ever conference. And so you just mark that on your calendar so you can come play with us for a day.
We love it.
More information will be forthcoming as everything continues to get set up, but we're going to bring in a whole bunch of really cool speakers plus time with us, and it'll be a blast. And as always, the podcast is intended for entertainment. It's not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Bye.
Bye, everybody.